All right. Well, we can go ahead and get started. Thank you all. Good morning, good afternoon, depending on where you are. Thank you for joining today's webinar entitled Understanding Spasticity and Those It Impacts. My name is Nikki Young, and I'm a program manager for the Child Neurology Foundation. Today's talk is part of our 2021 education series. Each topic focuses on what we heard from our partners and our families as a top priority. So first, I'd like to thank our 2021 education series partners. Without them, this wouldn't be possible. We have Amicus Therapeutics, Bluebird Bio, Greenwich Biosciences, CNS Therapy by LivaNova, Origin, PTC Therapeutics, Regenix Bio, Taysha Gene Therapies, and UCB. We appreciate your support. So today we'll be hearing from two speakers. Our first speaker is Dr. Ann Tilton, Professor of Neurology and Pediatrics and Section Chair of Child Neurology at Louisiana State Health Science Center. And our second speaker is Dr. Charles Steward, Patient Advocacy and Engagement Lead at Congenica and father of 2 children. Please submit any questions you have via the Q&A box, and we'll spend the last 15 minutes today getting answers from our speakers. So with that, I will pass it over to Dr. Tilton.
Thank you very much. As you'll see in the next slide, we're going to cover several things today. We're going to talk a little bit about definitions of cerebral palsy, causes, treatments available, and the importance of this information, which I feel quite sure you recognize because you have the interest here today. So what we do know about this is that, in fact, it's a puzzle. We are trying to figure out who is appropriate for treatment, what is the appropriate treatment, when and where. But also it's important for us to really look back on what were the causes of this. So I think it's important to start with the definition of spasticity, and I'm just going to take a few minutes today to talk about these issues. But I think it's interesting. It comes from the Greek word spastikos, and what it really means to draw or to tug. And if you talk to individuals who have this, it's kind of like having a tight rubber band and really pulling and having to walk and meet that resistance as they go or move or do any of their activities. But what we do know is that it's a disorder of muscle tone with a central nervous system cause. So if you're it says under the age of 2, and you can also see that in the next slide, that it's not only the muscle, but it's other things. But what's important to remember, it's neither a disease nor a pathologic entity. It's more of an umbrella. It really doesn't imply causation. It doesn't imply severity. Instead, what we know is that there are certain characteristics, although there may be multiple etiologies of it. So it's a group of disorders predominantly defined by movement and posture. Although that was the way it was really defined early on, we can now see it's accompanied by other things: sensation abnormalities, cognition, communication, perception, behavior, and seizures in some, but not all. So even if someone has a motor disability, then you have to recognize that, in fact, some of these other areas may or may not be affected. But it is a non-progressive disturbance. It occurs early in life, as I mentioned, typically under the age of 2 by definition, and due to the central nervous system having an abnormality. So what are the causes? It's interesting that the actual rate of cerebral palsy in the United States hasn't changed in 40 years. That kind of makes us take a breath, like I thought we were getting so much better with technology, with medical care. And the truth is we are. Because of that, however, we're able to save infants who are very small, under 1,000 grams, which translates to under 2 pounds, 3 ounces. And so those infants who are now able to survive that years ago were not able to, they are at risk, and we'll even have more numbers on how much that risk is if they're born prematurely or have other medical issues. It was used to be thought that a lot of people had lack of oxygen at birth, and it's true that some do, but not the majority. Also problems after birth, meningitis, and now a great deal of emphasis is pointing towards that there can be other issues, genetic issues, brain malformations that may be genetic in origin, but those are going to contribute maybe 30% of children who carry that diagnosis, and it's not another issue. So what does that really mean? Well, in the data from North America, Europe, and Australia, if you're born less than 28 weeks, you have an 82 in 1,000 chance of developing cerebral palsy, which means that you're in fact high risk at that point, 1 in 100, or 1 in 10 actually, close to that. So if you're born at 37 weeks or later, however, it's way down to 1 in 1,000. So obviously there's a great deal of effort to really preserve full-term infancy as opposed to having children born prematurely. But this still represents more than 750,000 children and adults in the United States. So it is an important issue for all of us. So the other thing that's important about it is about somewhere between 87 and 92% of these children will live to adulthood. And so the more we can do in childhood, the more understanding, the more intervention, the better it is, so that people can be more independent, more functional, and certainly more comfortable. So there are different types of cerebral palsy. You could have involvement of both legs, known as spastic diplegia. It could just be one side, which is hemiplegia. It could involve all 4 extremities, and therefore it is quadra for 4 plegia. Often is recognized, particularly in this young lady on the right, that there's some other phenomenon like called dystonia. So it's usually not pure spasticity. And then there's also dyskinetic. So kinetic means to move, dys means to move abnormally. So they may have what you often think of with children with cerebral palsy, although it is the minority, where they posture and have difficulties when they try to move, just that other muscles move simultaneously. So if we look at a treatment wheel, important is the evaluation, the goal setting, reevaluating as you go, and fundamentals are the rehabilitation. So what else can we add in terms of therapy? And we could spend hours talking about it. Well, we can divide this into kind of general, like it affects every muscle in your body, or we can say it's focal, it just goes where you essentially put it. So oral medications, we think of things such as benzodiazepines, which the trade name may be some of the brands you've heard, even baclofen, or we could talk about something more direct, such as botulinum toxin. And those are injected into the muscle that one wants to relax and predominantly stays where you leave it. So if someone has just involvement of their legs, you may not want to give them a medicine that relaxes everything, including their trunk if they have problems. Baclofen pumps are very good, particularly for the lower extremities. There's something called a rhizotomy. Some of you may be familiar with that, in which some of the nerves in the back are actually severed, the sensory nerves, so it turns down that dial of spasticity. And of course, the mainstay of orthopedic surgery, who really were very important early in this, but a lot of what we're doing is trying to prevent that surgery completely, which is very difficult, or at least postpone it till skeletal maturity. So what treatments are available? Well, I mentioned those, and you can see that they all work in different parts. And the reason I put this slide up is not so much that it is something that everyone may be completely familiar with, but it shows that we could combine something such as an oral medication and use botulinum toxin, or have someone with a pump and add other things. So it's not exclusive. It's all pointing to different areas where we're trying to improve people's lives and independence. Function is always the main issue, though. Are they better? So with that, let's see. I am going to turn this over to but I'm going to turn this over to our other speaker, which I'm very excited to talk to. Thank you very much.
Can you see my screen? Yeah.
Yeah, in slideshow mode, and we're good to go.
Hi, so, well, thank you for coming along. I'm Dr. Charles Steward, and I'm actually physically located in Germany, because my wife is German and we've recently moved to the Black Forest in Germany, but the company I'm employed by are based in the United Kingdom. So a little bit about me. I'm the patient advocacy and engagement lead at Congenica, which is a company that's based on the Wellcome Genome campus in the United Kingdom. And the company, it's a software company that enables clinicians and researchers to deliver sort of life-changing answers rapidly through the analysis and interpretation and reporting of genomic data. I said we're based on the Wellcome Genome campus, and the Wellcome Genome campus is most famous for the Wellcome Sanger Institute, which some of you might have heard of, because the Sanger Institute generated around 1/3 of the human genome. And I've been working on this campus for around 28 years, and I've done numerous different things, but I suppose the most interesting would be looking at the human chromosome 10 and identifying where the genes are. I was also involved in type 1 diabetes research. But I suppose, as you're going to find out later on in this talk, I was particularly interested in looking at the genome in the context of neurology, specifically epilepsy. And I actually did my PhD at the Wellcome Sanger Institute. So I also do, I'm actively involved in a number of different groups, all to do with patient advocacy, really, either as a patient advocate or as a scientific advisor. I'm a patron of a pediatric epilepsy charity in London. I advise to the United Kingdom Infantile Spasms Trust. I'm a governance council member for the International Cerebral Palsy Genome Consortium. I'm involved with Genomics England and Simon Searchlight. I also do quite a bit of fundraising and help to set up a charity which looks after children with cerebral palsy. And I'm also a co-lead for a project called FT3, From Testing to Targeted Treatments, which is based in the EU, but is actually a global group whose aim is to make precision medicine an accessible reality for patients. But most importantly, I'm dad to two lovely children who have severe neurological disorders. And I'm going to tell you a bit about them today. So this is our daughter, Imogen. And she was born in August 2012. And here she is at 1 hour, 40 minutes old. Here she's 2 weeks old. And just to say, she was actually born at 29 weeks. And she spent 4 weeks on intensive care. And here she is about to come home. And here she is Christmas, a few months after that. And things were going well until around springtime in 2013, when she started sort of regress in her development. She stopped taking interest in her surroundings, and she got really angry at different times of the day, which couldn't be soothed with drink or food or whatever. And then suddenly she started to do this. If you can notice, you can hear her cry, and then she looks to one side and her arms go up. She cries again. And then her arms point to the side in a figure of 4 shape, we call it. Her head turns and then her eyes roll. We took her to the Accident and Emergency Department in Cambridge in the UK, where she was diagnosed with a type of epilepsy called West syndrome or infantile spasms. And this is it's often referred to as a catastrophic form of epilepsy. And it's important to get the seizures under control because it's the actual seizures itself that can cause irreversible brain damage. Thankfully, her seizures were controlled after 24 hours and she began to develop again. Not perhaps as other children would do, but certainly it was an improvement. Anyway, 2 years later, Imogen had been diagnosed with cerebral palsy. We'd had a night vision camera installed into her bedroom. And it was very lucky we did, because one evening we put her to bed and something clicked onto the camera. And we could see slightly odd movement in her cot. So my wife went up to see her. and she was doing this.
That's correct, yes.
So this is me on the phone to the ambulance, emergency
Yes, we're number 4 on the right. We're cream coloured.
And what's actually happening here is she's having another seizure. And you see her lips are moving, her eyes
So
are
do you want me to go with
flickering,
you?
her
Or do you want
hand,
to go on your own?
you can see hand
Because I
here
can
is
bring a car.
moving, and gradually gets worse and worse. And what had happened is, she's having a seizure, and we have what we call something called status epilepticus. Most people who have seizures come out of their seizure after 5 to 10 minutes, but status epilepticus is when you don't come out of a seizure, and unfortunately, in some cases, the child will die. So the only way to come out of it is to intervene with medication. And thankfully, the hospital ambulance turned up very quickly, took her to hospital, where she had an electroencephalogram, which is all those wires you can see coming off her head, to see what the problem was. And thankfully, it was just a one-off seizure. And unfortunately, children who have West syndrome can sometimes go on to develop another really nasty type of epilepsy called Lennox-Gastaut syndrome. And thankfully, that was not the case. But we decided to enter Imogen into a genome study to see if we could understand why she had such challenges. And you may recognize this gentleman on the left here. His name is David Cameron, and he used to be the Prime Minister of the United Kingdom a few years back. And this is his son on the right, Ivan Cameron. And Ivan had a very severe type of epilepsy called Ohtahara syndrome. And he also had very severe cerebral palsy. And sadly, Ivan died at the age of 6. And as a result, David Cameron set up something called the 100,000 Genomes Project, which is run by Genomics England Limited. And the idea was to look at people who had neurological disorders to see if you can understand why they had them. And Imogen was entered into this genome study to see if we could find why she has such challenges. Now, I know this is a talk about cerebral palsy, but of course, cerebral palsy encompasses many different comorbidities. And I think there is actually a real lesson in history for cerebral palsy that we can derive from epilepsy. Because back in 1975, most epilepsies were characterized as unknown or idiopathic. And the term idiopathic is now no longer used. And in many ways, it was a bit of a fudge to cover up the fact that no one knew what the causes were for epilepsy. And this essentially provided an incorrect reassurance to patients that a diagnosis has been made. However, now we know that there are many genetic factors behind epilepsy. And in fact, technological advances such as MRIs have allowed us to view the brain at much greater resolution, identifying lesions that were not previously identifiable. And in fact, we know that a large proportion of previously unknown epilepsies now have genetic factors, including single gene epilepsies or more complex epilepsies, although the exact number of these remains uncertain. And now, even epilepsies characterized as acquired, such as trauma, stroke, or neoplasm infection or congenital malformations, are known to have a genetic contribution. And some researchers now believe that the chance of developing epilepsy is probably always genetic to some extent. And any person who starts having seizures has probably always had some level of genetic likelihood to do so. So in many ways, I feel that cerebral palsy is starting out on a similar journey of genomic discovery. And that the harder we look, the more we will realize that the genome is responsible for many causes of cerebral palsy. And in fact, recent genomic studies have shown that at least 30% of people with cerebral palsy symptoms have a genomic cause. However, I think the actual figure is likely to be much higher. I would say more than 50%. And in this study, you can see highlighted on the screen that was published just a few months ago, approximately half of individuals who were found to have a genetic CP would be likely to benefit from changed clinical management as a result of genetic findings. Now, of course, we have to be very careful about how we approach the cerebral palsy community with genomics, as perhaps some of you may have read about the Spectrum 10K autism study, which has caused a huge amount of concern in the autism community, because this genome study that I just mentioned, the Spectrum 10K study, was felt to not to have done enough, not to have had enough dialogue with the autism community, and they were very worried that it could be used to essentially breed out people who had autism. But of course, genetics can have can play a big opportunity here to make targeted treatments available for genetic cerebral palsy. And perhaps we might envisage some sort of overarching group, similar to the International League Against Epilepsy, or ILAE, to manage cerebral palsy and make everything consistent. And I include in that the actual messaging. I'd also say that preterm birth genetics is also a field that requires a lot more effort. The preterm birth is one of the most important causes of cerebral palsy, as we've already heard from Anne, accounting for about 30% of cases. Now, simply being born preterm does increase the risk of cerebral palsy, but most preterm births are caused by a pathological process, which would also influence the risk of cerebral palsy. However, research into preterm delivery has been painfully slow, and I'd say part of the reason is that obstetric research is an underfunded area of medicine, making it hard to attract academics to the field. And perhaps of equal importance is that the pharmaceutical industry is reluctant to get involved in an area with so much potential risk. So back to my family. We received Imogen's genomic results 1 minute, yes, literally 1 minute before we went in for Jasper's 12-week scan. Our clinicians knew that my wife is pregnant, and so worked really hard to analyze our genomes. And Imogen's result came back negative. They couldn't find anything. Nothing was found, but that in itself does not mean there is no genetic cause. What do I mean by that? Well, remember, we only know what a fraction of the human genome does at the moment. So, if we were to wait a few more years' time, when sequencing technologies are better, we might find something. Anyway, 16 weeks later, after Jasper's 12-week scan, he was born in October 2017 at 28 weeks, so a little earlier than Imogen. He spent his first 2 months on intensive care. And it was just before Christmas when we were told that there was a problem with his final ultrasound scan. We were due to be discharged a couple of days afterwards. And we were told that he had bilateral periventricular leukomalacia, which of course meant that he was extremely likely to have cerebral palsy, autism, epilepsy, etc. Anyway, so Imogen has grade 4 cerebral palsy, GMFCS, and Jasper actually has grade 4 to 5. He's developed that, sadly, over the last couple of years. Neither of my children can stand, and Jasper sadly, he can't talk. Although actually Imogen can talk to some degree in both English and in German, which is pretty good, pretty cool. And I just want to show you some of the equipment that we have to use, just to give you an idea of the sorts of challenges that we face at home. And this is actually our home in England. We left there 3 months ago. So we have manual wheelchairs, we have powered wheelchairs. This green powered wheelchair was bought for us by a charity. It's actually around £23,000, well out of our budget. So we have various bits of equipment in our children's bedroom, including a night vision camera, a hospital bed, anti-suffocation pillow, toileting and shower chairs, as you can see here. And then we also have special chairs for them to sit at during meals, and also standing frames, because of course, as they can't stand, they can't use the muscles in their legs. So these standing frames help them to do just that. And finally, here is a picture of my family. It's my wife, Svenja, Imogen, and Jasper. This is them recently in Germany. And I'd just like to say thank you to all of these groups on here, and including 2 special people I got to know recently, Jeff D'Angelo and Luke Rosen. And Jeff and Luke have these gene-specific groups. Luke's is KIF1A and Jeff's is CHAMP1. And both of their children had neurological disorders that are often mistaken to be cerebral palsy, but we now know through genome sequencing that they actually have a genetic disorder rather than just normal cerebral palsy, should I say. So thank you.
Thank you very much. I think that's exceptional, and I think we'll get a chance to talk a little bit and to really explore some of the things that you've done. And so I thought I would start really asking you to tell me a bit more about your work in genomics.
Yeah. So I mean, I guess it's a blessing and a curse, really, to have been a genome scientist before my children were born. But yeah, so I've worked on the human genome in one form or another since 1994. I have not left campus in my career. Some people say it's a lack of ambition. I would say go visit the Wellcome Genome campus and see how beautiful it is. I mean, because the work we do is just so exciting, so groundbreaking. And you know, I've seen the Human Genome Project sort of evolve from we'll get it done in 50 years time into well, now we can sequence a human gene, you know, we can sequence a genome in a matter of hours. Yeah, it's getting quicker and quicker. So yeah, so I originally worked on the human genome. I've worked on a couple of other fancy genomes, wallaby and platypus. You know, there are good reasons for sequencing these. It's not just a bit of fun. You know, there's some really interesting scientific questions that you can ask about these different organisms. And of course, you know, if you want to study the human life cycle, you have to wait 80 years or so, you know, to follow it from beginning to end to see what happens. So this is why we often look at the genomes of things like the mouse and the zebrafish, because you can see a whole life cycle in sort of a matter of months. So you can study what a gene might do in a period of time. So I've worked on various different genomes, but of course the human genome was the key thing for me. And it was fascinating looking across the whole of the human genome as we were doing. But there was never really any real sort of specific interest, I suppose, that I had. And it wasn't until my daughter was born, you know, obviously, and she had that really severe epilepsy, that I began to use my connections in genomics to start investigating the causes of, you know, these really nasty neurological disorders. And I think what I probably didn't make clear from my talk is that it's looking increasingly likely that probably the genetic cause, and I believe there's a genetic cause behind my children's birth. It's curious how similar their births were and how similar their MRIs are. I believe that there's some sort of underlying genomic cause that caused the premature birth. I don't think that they have a genetic cerebral palsy, as I mentioned. But I think that the genetic cause is behind, probably to do with the placental abruption that they both had. There might be something to do with blood clotting, you know, those sorts of genes. And the actual epilepsy that my daughter had is a direct result of the brain damage caused from her premature birth and from her cerebral palsy. So I've been looking at epilepsy, and I think I kind of took my eye off what was probably going on with my daughter and really overlooked the cerebral palsy, because when you have a diagnosis of something like West syndrome epilepsy, there are so many awful disorders that can cause that, things like leukodystrophies, that you get a diagnosis of non-progressive cerebral palsy, and it comes as a relief. It sounds weird, doesn't it? It sounds awful, really, in many respects, but you know that it's not a really progressive disorder where your child regresses and unfortunately then, you know, and then dies. So I was looking at epilepsy. I got really heavily involved with the clinical world. So we were entered into 100,000 genomes. I got to know the people there really well. And I moved to Congenica, because Congenica, as I briefly described, you know, we are a software company that helps clinicians and researchers to look into the genomes of people and try to look for what might be causing their disorders. And I've had the platform there to really reach out and use my personal experience, but also my scientific experience, to advocate for people, to advocate internally, to tell all those, we've got loads of programmers, a lot of them who've come from outside the field of health, outside the field of genomics, to make them understand that, the importance of what they do and why it's important they get it right. Their programming skills, they need to get it right, because ultimately people's lives will depend on it. So genomics is my passion, more so, I think, since my children were born, and doing what I do now means I'm able to reach out to a lot of people, and give them also, to give these people a sort of a platform to talk about their rare diseases.
That's an amazing journey. We did have a question from the chat, and I may just jump in on it, and it had to do with vision. Do either of your children have visual concern? And the question sort of extended into, are there genomic studies or other things that might give us insight to that?
Well, yeah, I mean, what I perhaps should have done is also put up a list of comorbidities or other things that coexist with cerebral palsy. And I mean, yes, I mean, blindness and deafness are obviously the most extreme forms of vision defects, and they are common, I would say, relatively common in cerebral palsy. Both my children had squints when they were born, and my daughter was going to have surgery, but she developed her really nasty epilepsy, so she couldn't. My son, he has had squint surgery, so he had both eyes I think he had squints, so he had corrective surgery. Because he hasn't had epilepsy or obvious epilepsy yet, he was able to go forward for surgery. He's had corrective surgery done, and both of them, well, my daughter has glasses and my son will also have to wear glasses. So I'm not sure if that quite answered the question, but there was also the question about genomics, wasn't there? What are the, there are a number of people who offer genomic testing, but I mean, the problem, and this is why, and this is why I'm so passionate about cerebral palsy, is that it's still many people just think of it as an accident at birth, and we have this problem in the United Kingdom where we are beginning to use genome sequencing routinely, but not everything can be sequenced. You can't just rock up at a doctor and say, "Can you sequence my genome?" There is a test registry with lists of things you can search for, but cerebral palsy isn't one of them at the moment, and that's why we're working really, really hard with clinicians and researchers in the United Kingdom, but also with the International Cerebral Palsy Genome Consortium, to make a case for cerebral palsy to be offered as a frontline sort of option for people with cerebral palsy. I don't know what it's like in the United States. I know that some people offer it, but obviously you then have to pay for it, I guess, and whether that's reimbursed, I don't know.
Right now, there is actually a company called Invitae, and I guess I shouldn't mention that, but the bottom line is, as someone
are available,
as someone who does a lot of work with cerebral palsy, they have recognized and have implemented a screen for mimics, because it's well recognized, just like you've been emphasizing, that there are mimics of cerebral palsy. And within those mimic questions are very rare genes, which may have therapeutic implications. And so we are able to go ahead and swab or saliva and get that done in the United States.
Yeah, absolutely. I mean, one of the other things that we're doing at the moment is doing literature searches to identify genes. For example, as I mentioned, KIF1A and CHAMP1. These are genes that give the appearance of cerebral palsy, but it's quite clear from genetics that that's the cause of the cerebral palsy, so to speak. And we are generating lists of these genes to help us to identify more patients with cerebral palsy. I believe it's a huge untapped cohort of people that we could help. Obviously, there aren't treatments for everyone, and there are treatments. There are a lot of people who won't have treatments. But, we're at the stage of where precision medicine is a real thing. And, as the years progress and our technology gets better, there will be more opportunities and technologies that will be able to help people.
I think that's, incredibly important. We talked earlier when you and I were speaking about early intervention. And so I was just thinking about your experience with early intervention and some other thoughts on that.
Yeah, I mean, I know we're talking about spasticity, cerebral palsy, but we can't forget that there are all of these other I call them comorbidities associated with cerebral palsy, and the one I've talked about a lot today, of course, is epilepsy. And what I think is really important is, it's a really rare epilepsy, and it's, often a general practitioner will never see that epilepsy in their lives. So there's a need to educate doctors to look for red flags, look for the stiffness in the child, perhaps look for developmental regression, and be really quick to treat, what is a devastating epilepsy, which is, it is a fatal epilepsy in some children. And then, of course, you need to get in early for things like physiotherapy, because often there is hip dislocation, and actually we had a really good orthopedic surgeon, because Imogen had to have a double femoral osteotomy and tenotomy, which is it's a hard operation for anyone to have to go through. And normally what happens is you do it when the child is quite young, you open them up, you cut the femur heads off, and you sort of shape them so they go back in, and the child has to wear something, I think it's what we call a hip spiker, which is it's a sort of a plaster cast you have to wear for months, and it's very difficult to clean the child. It's very difficult to get to the nappy, and it's just a pretty miserable existence. And we had a really amazing orthopedic surgeon, Kuldeep Storr. She'd married a German man, so she spoke German to my little girl, which is fantastic. When they were going through all the consultations, she was lovely, and she put everyone at ease. But she said, well, we're not going to do Imogen's surgery when she's really young. We're going to wait till her bones are stronger, and when her bones are stronger, that means we can put her into a special cast, which is just around her legs, and you can get it's a much shorter type of cast, and it just keeps her legs slightly apart. But it means that you can change her nappy easily. It means you can take it off from time to time, and you can take it off and bath her and put it back on again. Yeah, I mean it's and this made everyone's life so much easier. I mean it's having. I think we were lucky that we had Cambridge University Teaching Hospital, Addenbrooke's, close by. It's a big tertiary hospital, and it's a huge biomedical campus. I think it's probably the second largest it will be the second largest in the world, behind somewhere in the United States. I can't remember, but anyway, yeah. I mean, we were lucky that we had some really amazing clinicians who knew about the best practices. So.
I mentioned earlier that some of what we do with our medications and botulinum toxins and pumps and everything is to allow the children to get more skeletally mature, so that you don't have birthday surgery, but instead have the opportunity to get skeletally mature. And so that's part of hopefully what we do when we educate people about what our hopes are for the goals of the medication. But I think that's really interesting.
Yeah, I just mentioned really one of the, there are challenges every day, and every day is not an easy day. but things that would make our life easier, for example. I was saying this is in the UK, and I don't know how it is in the United States. So our pharmacy, they try to get the best deal for baclofen that they can. And that means that they don't get the same baclofen in every time. And what that means is that the different baclofens have a slightly different flavor and a slightly different viscosity. And you try giving a child with learning difficulties and all sorts of stuff, a different medication from time to time, they hate it.
Yes.
Yeah, and it's difficult to actually get them to take it. So I appreciate probably different firms make it and it tastes different, but it would make our life much easier if it was exactly the same between the two. And in Germany, they don't have liquid baclofen, so we normally give it with a syringe. And in Germany, it comes in tablet form. So you can imagine trying to administer a tablet to a 3.5-year-old who bites and scratches. We've come up with all sorts of different ways of doing it. And now, because we sometimes have pancakes, scrambled eggs and bacon with maple syrup for breakfast, and my son loves it, we now mix up his tablet into maple syrup and we top line, and I think it seems to work so far. But yeah, I mean, just the different ways of doing things. Yeah, it's hard. It's a different way. You have to adjust. If it was just one way of administering the medicine, it would be much easier. But
Raises the multidisciplinary thing, but maybe I'll turn it over to Nikki for some of the questions.
Great, thank you both. We're getting a lot of great questions in the chat, and a lot of these are around treatments for spasticity. So the first one we're getting is, what is the first line treatment for pain with spasticity? Spasticity is common and degenerative. We currently don't use any treatment, but we'll start to need something soon. So what would you share with that?
I'm sorry, the first treatment just for cerebral palsy in general? Is that what you mean?
First line treatment for pain with spasticity.
Oh, for pain with spasticity. I think the way that I approach it is to find out, can I identify the origin of the pain? It can be any number of things. It may be the hips. And if that's the case, then clearly they would be involved with orthopedics. If it's spasticity, cramping, pain, that sort of thing, then you can do it in a global way by starting medications such as baclofen or maybe even diazepam. And you also, if it's specific, if you can identify it, then injecting is important for maybe reducing the discomfort in the adductors, hamstrings, or upper extremity. So the identification. I've also had luck when people, they're very irritable and it turns out that it's stomach irritability. And we use GI medications, gallbladder problems. We can't forget that these children have other medical issues. And we have to look at that. I'm going to go to mute for a second just to help y'all.
Thank you. And there's a couple other questions around your treatment wheel, for one. So, where do you kind of start on that treatment wheel? And then there's a couple of questions around non-conventional or holistic treatments to ease spasticity. And have you or would you try any of those?
Well, starting, I think that everyone has to recognize that there's a fundamental, and that is that like a muscle needs a minute of stretch every 12 hours. So it's important to get a rehabilitation plan, PTs, OTs, speech people, that multidisciplinary team. But what you do at home is more important than what you do 30 minutes twice a week. So every diaper change, I have people do things. So that's one component of it, the stretch, all of that. I also, talk about if we're going to do some other kind of intervention, it's basically after the foundation of the rehabilitation approach. So I've had people say, oh, good, you gave him botulinum toxin. Now I don't have to stretch anymore. And no, that's not it at all. I'm helping you. I'm helping you do that. So those are the things that we do recommend. So I start, again, identifying what the individual things are for the patient, identifying what the goals are. It may be care and comfort. It may, in fact, be functional movement. So you have to identify goals and the foundation of the stretch, then specifically go to the individual. So it used to be, it was a ladder. You had to fail oral medications, and you did this. And it's not like that. It's that sort of, if you will, Chinese dinner of group A, B, and C, and you can pill and pull and put, and that makes it sometimes more challenging, but also a lot more options for us.
So Dr. Tilton, how would you say treatment for cerebral palsy has changed in the last 15 or 20 years?
Oh, it really has. And again, all kudos to orthopedics, because it used to just really be primarily orthopedic and rehab and orthopedics and surgery, and again, that sort of repetitive surgery approach. But now, and some oral medications, I think some of the newer things that have come up are the botulinum toxins. I've been doing them forever, but I really do think it's changed the course, whether it's changing how your motor planning is even at a central level, but just relaxation, and again, hopefully postponing things or avoiding them. There's something called the Rhizotomy. I didn't go into it. That was used many, many years ago, but not well, and that's come back into play because it's now selective as opposed to complete, where they sever some nerves in the spine. Obviously, there's a specific person that needs that. The intrathecal baclofen pump has been a major advance because you're delivering that baclofen that you're taking orally, or you have to have many times the dose to get it to the spot. You're delivering it directly at a fraction, and so you don't have the cognitive side effects. And obviously that's really important because that may be something that is one of, and it often is, someone's strength is their cognitive abilities. So you don't want to, interfere with that. And clearly there are other things out there now. We're doing deep brain stimulation, which is coming up for some of the movement disorders. And I didn't get into that either. Another day, another time. But it's some fascinating work, and development of medications, and the genomics is just major because some people may really benefit from some specific therapies.
Someone actually just piped in and asked if deep brain stimulation would help spasticity.
Oh, it has a role in the dyskinetic, the one that has much more of a movement disorder, which can evolve later, even though you aren't really deteriorating. And so for like chorioathetosis and maybe some dystonia, it's we haven't gone through all those definitions, but you want someone who has some experience identifying and defining cerebral palsy to say who's the right person for it.
Now, one person is asking about, and you may or may not be able to answer this, around cannabis or THC for treatments. If you're not able to answer that, just let us know.
I don't have much in the way of studies. It certainly has been described. I think probably work will be going on that. We do know it has a role in epilepsy, as not the THC component of it, but the Epidiolex is the medication that has been shown to help in a specific type of epilepsy called Dravet, and in some of the Lennox-Gastaut you alluded to. So there is clearly more going on understanding that medication, but we really don't know what's in a lot of the stuff that just is here, you don't know what's in. So I say, wait for the science.
I have heard some clinicians talk about cannabis and spasticity, but whether that was a clinical trial or not, I don't know. Yeah, I mean, it's what the clinicians.
People may be more relaxed. Hot water work. I mean,
Yeah, absolutely. I mean, Imogen, she had Botox to help relax her, and also the adductor tenotomy, which just obviously cuts the tendons in her thighs, and that helped for a while. But of course, you grow and then the same problem occurs. And I don't know how you. I mean, do you administer Botox? Oh, your clinic does. We had to have it done under general anaesthetic, which again is, I mean, my children have been through a number of general anaesthetics, and I'm just a bit nervous about doing it too many times, when they're small. So I mean, that's
Well, I've been doing, botulinum toxins for, I can't believe, we did it at the very beginning. So I've been doing it over 26, quite a while. I know I don't even want to admit to it. But at any rate, we don't do it under anesthesia. I'm so fast. We use coolants, we use lots of other techniques, and we're able to, I can do adductors and hamstrings in less than 2 minutes.
Yeah.
And then they're gone.
So we use, or say we use, I think it's what we're having in Germany, but we also have in England, is conductive education. Andreas Pato is his name, from Hungary, I think.
Peto, yeah, but Peto.
Something like that, yeah. And that's, there is some neuroplasticity. I think that the brain is plastic for a lot longer than we really thought. I think I read recently that. So that there are sort of exercises to do which can really sort of help to develop, I think, new pathways in the brain. So that's something that we do, and that's what they're using in Germany on my children. So.
And I think that's part of an individualized approach. That's our learning approach. I laugh and say that, we continue to myelinate, put the insulation on our nerves until, all the way to the frontal lobes for executive function, until we're in our 20s, which explains a lot. And it also explains why rental car dealerships will not rent to anyone under 25 without special dispensation. They figured it out long before we did, that we're still doing. Plus, we learn. And so if we learn, we have pathways, and we're making pathways all the time. I mean, whether you're trying to learn a language, or just more agile, shall we say, when you're young. And maybe we can intervene early. And that leads to multidisciplinary teams. But I think you may have some questions before I go there.
Yeah, we have a couple more before we wrap up. Try to get to these. Charles, did want to ask, there was one question around any treatments that you've tried for your children, holistic or alternative therapies. And then I also wanted to ask you too about any resources or anything that was really beneficial for you in your family.
Sorry, can you say that one again? What's
Yeah, so the first question was around any holistic or alternative treatments you've tried for your children, and then any resources that maybe has helped you along the way.
Things that help. Well, yeah, my wife is a big believer in oh crikey, what's it called? I've completely forgotten what it's called, but it's where you drop little sugar balls into water, and what's that called? You dilute medicine down so far that it's meant to. Anyway, my wife is kind of into alternative medicines, and I don't know why, but it works for her. It genuinely works, and she has used this for constipation for my daughter, and it seemed to work. And now I'm, as a scientist, it's difficult for me to explain this, but perhaps there is some sort of psychosomatic sort of idea that it's a bit like the placebo effect. These things sometimes work. So I'm all for trying things that that are not going to interfere with the health in a bad way. So yeah, we obviously, as desperate parents, you do try anything, and I do hear stories from other parents, really desperate parents who, they've gone to all sorts of lengths to help with oxygen, extra oxygen for the child, even things like stem cell therapy, and of course stem cell therapy, you have to be really careful. If you have a genetic cerebral palsy, and then you take brain cells and derive stem cells from them, you're essentially taking diseased cells to try and make better cells. So this is a really, you have to be really careful. But when it comes to things like things that have helped us, I brought this along. This is Imogen's spoon, and she finds it very difficult. She's got poor mobility in her hands. She can't hold the spoon. So this is just literally plumber's lagging. You can buy it in any hardware shop, I'm sure, and just pops that over there. and that helps her to hold her spoon, and then she can use it quite normally. And we also use these, not so much now because Imogen is really quite big, but for my son, if you want to go and use a slide or whatever, or sorry, a swing, you know, it's often you're never going to find a disabled, accessible swing around. Although people are becoming more progressive, should I say? And we use these anti-slip mats. You put them on the seat, and that stops him from sliding off and allows him to enjoy the swing. So we've got lots of little tricks of the trade, but those are two particularly easy ones I would suggest.
Thank you. That's awesome. I love hearing those. I'm sure other families do as well. So I'm going to share, there's lots of questions around treatments for spasticity. So I'm going to share our disorder directory page in the chat. You can find this on our CNF website if you search for spasticity. Lots of great information on there, and we just recently updated it. So hopefully any questions you have can be answered there. Do need to wrap this up for the day. So thank you all so much for joining this webinar. It has been recorded and it will be made available on our website in the next week to view or to share. You'll also receive an email notification when the recording is available. So if you have any additional questions for the Child Neurology Foundation or for our speakers, just contact our programs inbox. So it's programs@childneurologyfoundation.org. And you'll also receive a survey link for this webinar. Let us know how we did, what you'd like to see in future webinars. Check out our website, sign up for our newsletter, all that good stuff. We have lots of great resources for you. Thank you so much. Appreciate you all being here.
More to come. Thank you, Charles. I've enjoyed it so much.
You too. Thank you.